Good morning, everyone. I'll be doing my presentation on patellofemoral joint arthritis, looking at the indications for treatment. So a little bit of background. So we know that patellofemoral arthritis is a very difficult problem to manage. First, stemming from identifying what's actually causing the pain. Anterior knee pain has multiple pain generators, can be coming from the joint, the synovium, and then more periarticular structures, the retinaculum, the fat pad, the bursa, the patellar tendon. So first of all, it's very important to identify the actual source of the pain, and then the things that make it difficult are also identifying what any of the associated pathomechanical factors, things like alignment, play a large role in the tracking of the patella, and the balance of the muscles and the soft tissues around the knee also contribute to this. And putting all this information together helps us decide how we can manage this, both by non-operative and operative means. And we know, unfortunately, that a lot of the cartilage, salvaging procedures have limited success. In terms of anatomy, the patella is the largest sesamoid bone in the body. Essentially, it has a lateral and medial facet, generally with the lateral side being equal to or greater than the size of the medial. It has the thickest cartilage in the body. You can see on the color chart there that has up to 5 millimeters of thickness, and then petering out to about 2 millimeters peripherally. And this is important to note because this shows us that the thickness of the cartilage actually differs throughout the patellar surface, articular surface, and the other thing to note that is obviously the patella increases the mechanical advantage of the quads, and that's its main function. The femoral trochlea is made up of the medial and lateral facets as well as the groove. Once again, the lateral facet is slightly larger than the medial, and on an axial view, the sulcus angle, which is normally 137 plus minus 8 degrees, helps us determine whether it's a shallow trochlea or one that's within the normal range, and this has implications for stability as well. And once again, similar to the patella, it's also interesting to note that the shape of the articular cartilage surface does not often correspond to how the bone is shaped underlying. So when you do look at a skyline view, it doesn't, and you think the joints line up, it doesn't exactly mean that the joint is congruent at the cartilage surface. In terms of trochlear dysplasia, de Jure came out with a classification for to classify this on a lateral X-ray at 30 degrees flexion, and a type A is a shallow trochlea with a sulcus angle of greater than 145 degrees, and often you can see this crossing sign, which is the elevation of the floor of the trochlear groove, and that rises above the top of the wall of one of the femoral condyles, and this can be seen on a lateral X-ray. Type B is more of a flat trochlea, and sometimes you can see a supratrochlear spur at the top there, and then a type C is a one with a lateral convexity and a hypoplastic medial femoral condyle, and that can be seen as a double contour sign on a lateral X-ray. And then a type D essentially is similar to a type C, but has a vertical link between the medial and lateral facets. In terms of the patellofemoral joint, functions increase the lever arm to gain better strength from the quadriceps muscles, but it also changes the direction of pull of the quadriceps. Importantly, for stabilizing factors, the lateral trochlear facet is the main stabilizer for the patellofemoral joint to prevent dislocation laterally. However, this is only once the patella engages with the trochlea, which is at about 20 degrees of flexion. Before this, so between 0 to 20, the main stabilizer is the soft tissue structures, the MPFL, and to a lesser extent, the patellotibial and patellomeniscal ligaments, as well as obviously the dynamic stabilizers being the VMO. In terms of biomechanics, I've touched on this a little bit already, but from 0 to 20 degrees, the patella translates medially, and then beyond 20 degrees, once the patella engages with the trochlear groove, it will move distally and laterally as we increase in flexion. And from 45 to 90 degrees, that's when we have the greatest contact area between the patella and the trochlea. Other things to consider, so increased Q angle. So Q angle is a line formed, so the angle formed between a line from the ASIS to the middle of the patella and the line between the middle of the patella and the tibial tubercle. And traditionally in females it's been greater than males. In females it's about 18 degrees and males about 13 degrees. And an increased Q angle and also a genu valgum increases the lateralization force of the patella due to the force vectors of the quadriceps. And this has an effect of essentially increasing the potential for the patella to track laterally, and this has implications with regards to reducing the contact area between the patella and the trochlea, and eventually causing increased patellofemoral joint stress. The other thing to consider also is the position of the patella. So if, in terms of from a sagittal point of view, if the patella is outer or high, then it's often associated with instability, as it requires the patella to be more in high degree of flexion before it actually engages with the trochlea. In terms of how they present, classically these patients have difficulty with stairs and squatting, and perhaps prolonged sitting as well, and there may have been a previous trauma, whether that's a patella fracture or a dislocation that may have caused an osteochondral fracture. On examination, they may present with an antalgic gait. Coronal alignment is important, so to assess whether they have genu valgum. And in terms of tracking, hopefully this works, but they often have a J tracking, and that's with the patella kind of migrating or translating laterally as the patient extends their knee. Crepitus can be felt around the patella on palpation, and if they have had issues of instability, certainly there is potential for greater amount of medial and lateral displacement on stressing the patella as well. In terms of imaging, for patellofemoral arthritis, it's important first to get a knee series. A standing AP will help signify whether there is any evidence of tibiofemoral arthritis, which is important when deciding management. And then looking at the lateral at 30 degrees, you have you can see there we can use Blumenstadt's line to help determine whether the knee is in outer or neutral or Baha, and generally this line will intersect with the distal pole of the patella. Other ways to determine the height of the patella is those other methods there, the Canton, Deschamps, Blackburn Peel, and Insal-Savati, and they're all ways to measure the height of the patella. I'll just note that the Canton, Deschamps, and the Blackburn Peel, people have said that it's more beneficial to use that method because it can be used to describe positional changes after a distalization procedure, such as a tibial tubercle transfer. Obviously, skyline is important to determine the sulcus angle, and and a long leg alignment is very useful to see if genu valgum is a contributing factor. In terms of CT, TTTG, or tibial tubical trochlear groove distance, is an important measure. It is a measurement of the lateralization of the tibial tubicle in relation to the femoral trochlea, and you take a measure from, there's a tangential line along the posterior condylar axis, and you draw a perpendicular line from that to the most anterior part of the tibial tubicle and the deepest part of the groove, and often a measure greater than 20 mils is abnormal and is an indicator of instability. Another useful investigation is doing a CT and at varying degrees of flexion, and this is more for when you're planning for a distalizing procedure of the tibial tubicle, and this shows the position of the patella at 0, 10 and 30 degrees, and this may dictate whether a distalizing procedure would be beneficial for this patient. An MRI, once again, is useful as well. Once again, you can do a TTTG measurement of the MRI. It's also useful to measure the patellar height, but importantly, you can assess the articular cartilage, as well as any other associated injuries with the knee, whether you want to assess the MPFL, whether you want to assess the menisci as well. In terms of management, the non-operative measures really need to be optimized in these types of patients, and they're really aimed at addressing the biomechanical issues that may be underlying, such as strengthening of the VMO and stretching the tight lateral structures. And this method, McConnell taping, which I used to use a little bit when I was a physio, works in two ways. So obviously it's pulling the patella medially, and one, to relieve the pain and improve the tracking of the patella, but it also helps more as a biofeedback mechanism to try and activate the VMO. In terms of cartilage restoration, the procedures, the debridement and chondroplasty procedure is of limited value. It's really indicated only for unstable chondral flaps that can be debrided back, and definitely not for larger areas of chondrosis. And other techniques that we're familiar with, the microfracturing, once again for smaller lesions on the trochlea. We know that the microfracture will stimulate the subchondral bone, which induces the stem cells to form fibrocartilage, but we know that this is a different type of cartilage to the hyaline cartilage, which is more durable, and because of the shear stresses that the patellofemoral joint undergo, these often don't have great outcomes long term. And if you are going to do something like this, it's important not to drill too deep, as it can impact and compromise. So it can damage the subchondral plate, which can have issues if you're going to plan to do another procedure, such as AC, which I'm going to talk about shortly. I guess until so. Yeah, I did read this, sorry, but my understanding is that once you start seeing the fat, I think that's probably a good time to stop. So another method is the osteochondral autograft transfer, or mosaicoplasty. These are generally good for lesions less than 2 centimeters squared, so smaller lesions. And I guess what happens is you take your graft from the non-weight bearing portion of the medial and lateral femoral condyles, and you plug them in to the defect. Now, the issue with this is, as I mentioned before, that the the contour of the trochlear groove and the patella is not flat, and so it's very difficult to restore that articular congruity, and it's quite easy to leave the plug a little bit proud or to bury it, essentially, which would lead to increased contact pressures and will cause the symptoms to reoccur again. There are well-described methods of autologous chondrocyte implantation, or AC, and therefore reserved for slightly larger lesions, and really for patients, younger patients who are fitter, and it's more, I guess, an option for more as a stopgap rather than a definitive treatment. The procedure really is a staged procedure where you take a piece of cartilage and then you take it to the lab and you culture more cells and reimplant it. And you can do that by with or without a matrix. The advantage of using a matrix is that it doesn't require any suturing and the cells are embedded in the matrix. With the AC, you can get cells that leak out, and you do have to harvest a periosteal flap as well. But both these methods, it's contentious in the literature, and there is no real good RCTs and high-quality studies that are adequately powered to prove its long-term efficacy. And then allograft transplantation really is for young patients with large lesions, and it's really for people that you don't want to provide an arthroplasty option for, and really to try and delay that process. Advantages are it eliminates sternocite morbidity, but it does have a significant costs attached to it and the risk of disease transmission. Another technique, more just for isolated lateral facet arthritis or arthrosis with a patella tilt, a partial lateral facetectomy, something that I've seen from time to time in my practice, and works well in patients with this isolated form of arthritis. And the main contraindication is that you can't do it in an unstable knee, because essentially you would be making them even more unstable by doing the release part of this procedure as well. And there are good quality studies that show that this has good medium to long-term effects. One thing to do before this procedure, and one thing to consider, is also to see whether this patient responds well to the McConnell taping as well, as this has a good prognostic indicator, similar to doing like a cortisone injection into the subacromial space for patients that may require a subacromial decompression. Finally, we've got the arthroplasty option, and really indicated for people with isolated PFJ-OA who are refractory to any non-operative measures and cartilage restoration methods. And obviously you don't want patients who have got arthritis in the other compartments, any issues with maltracking and malalignment, which really should be addressed before doing this procedure, inflammatory arthritis and chondrocalcinosis, being other contraindications. And the registry data is not great in terms of revision, but we know that the indications for patellofemoral arthroplasty can be different to indications for someone with tricompartmental knee OA, and really it's aimed at a younger cohort of patients with higher functional demands. And in terms of preoperative considerations, once again, correcting any biomechanical issues and any malalignment issues is very important first to do. Once again, postoperatively, we do have the higher revision rate, and the main complication being progression to tibiofemoral arthritis, loosening, pain, and wearing of the prosthesis. And In terms of conversion to a total knee replacement, there are studies out there that suggest that it is a relatively straightforward procedure. The index procedure for the patellofemoral replacement, you don't lose a lot of bone stock during that procedure, and it's a fairly straightforward revision procedure, and the patients seem to do quite well. So in terms of the take-home message, first, it's important to identify the source of the pain and identify any of the underlying pathomechanical factors that could be contributing to the patellofemoral symptoms. And we know that it is a difficult issue to manage, and there are limited success with the cartilage restoration techniques. But definitely for your younger, more active patients who have isolated patellofemoral arthritis, I believe the arthroplasty option is a real option for those patients, knowing at some stage that there will be a progression to tibiofemoral arthritis and potential to need to convert it to a total knee replacement. Thank you.